I invite Dr. Hiremath to take us through what the bioabsorbable stents promise to address some of the issues that were highlighted by Ajay as well as Saurabh. Hiremath.
Hi, good morning. So as you see the stent evolution going, this is something we will always talk about, the polymer going away from the stent. As you all know, we always talk of three components, the drug, the polymer, and the stent platform. And today we are talking in next 10 minutes about the polymer getting degraded from the stent. The drug, of course, is important. The drug has to be held in position, and for this the polymer has to come in, though there have been lots of modification in this area subsequently. The polymer actually is a combination of small units, monomers, which actually form a macromolecule. And we are familiar with these polymers, say in breast implants, artificial vials, and so on. So as you see here, the polymer is important for locally delivering the drugs, control of drug release, and also to improve the drug stability in vivo. This is especially important in a country like ours where temperatures are high and the stent is carried from one lab to other just at the request of a phone call. So the stability, again, is a very important aspect given by the polymer to the drug. Also in vivo, when we are trying to introduce the stent, so many times we have to take out the stent, make bed, and again reintroduce. The stability has to be maintained, and the polymer helps to reduce the drug contact with the tissue enzymes and retains the drug at the site of treatment. This is extremely important because ultimately the drug delivery is the one which is going to decide what's going to be your restenosis rate. We all know that the drug is delivered in a different fashion. Most of the stents use drug delivery time between 30 and 40 days. There is an initial burst of drug delivery, and then there is a slow release. All these is modified by the polymer. So when you talk of polymer, we have 2-3 components which are very important. One is the biocompatibility, and we know that the biocompatibility, mechanical integrity, and bioabsorption, if these three are on the higher side, the safety is preserved, but the efficacy goes down. So does it mean that bioabsorbable polymer is going to have a less efficacious stent? I think when we get to the studies, we know that these biocompatible, biodegradable polymers are also as effective as the conventional stents. So we have durable polymer, and we have examples like Xience, where the layer is thin, it's 0.13 microns, and we have bioabsorbable polymer used by Biometrics or Nobori. Again, the thickness is about the same, 0.13 microns. We have fluoropolymers used by Xience as well as Promos Element. These are the kind of polymers. While we know that when we moved from Endeavor Sprint, which had phosphorylcholine as a polymer, to Endeavor Resolute or Resolute Integrity, which has BioLinks as a polymer, the delivery time was increased from, say, about 10-11 days in Sprint to about 30 to 40 days with Resolute Integrity. So all these variations in drug release also come via polymers. And these are the kind of polymers that you talk about these days, the PLLA, PLG, PLGA, and so on. And also there are non-polymer technologies where the drug is held by some other means, like there is a nanotechnology where the particle size is very small. There are textured surfaces, there are depot preparation. All these will have its own way to hold the polymer in place. The Yukon choice actually was unique because it was totally polymer free, having its different kind of drugs could be used, different dosages could be given, and so on. And then now we talk about the abluminal coating in the sense that the drug and the polymer is only towards the vessel wall and the lumen is like a bare metal. So this again is a very aggressive, active thinking that the drug will be delivered only towards the vessel wall. And this is King of Kings, where everything seems to go. The current problem with the polymer, of course, is the non-uniform polymer coating. Whatever you do, you see the technology by which the polymer sort of gets onto the metal. There are reasons to believe that there could be sort of unequal coating. There are web polymer surfaces leading to stent expansion, and there could be polymer de-elimination. All these could possibly result into long-term problems of poor healing. Thrombosis risk is increased, and there could be a continuous source of inflammation which lead to various problems. The biometrics, which many Indians are familiar with, is again an abluminal coating. The 50-50 drug and the PL, polylactic acid polymer. The polymer goes away, and this is the stent which is compared with sirolimus eluting stent in leaders, and we know from leaders data going over to almost 5 years that the composite endpoints are clearly superior with biometrics compared to Cypher. This is actually a 5 years target lesion revascularization, again clearly superior in biometrics compared to Cypher. In the ST elevation subset, again biometrics looking good on overall MACE. And you pick up all the subsets, diabetics, ACS, ST elevation, left main, the biometric seems to do better than the Cypher on the other side. So this is what we are talking about. The stent should be very smooth a few weeks after the stent is deployed, and this could avoid late stent thrombosis. In OCT studies in leaders, you find that the lesion with 5% uncovered stent struts clearly less in the biometrics eluting stent compared to Cypher, and lesions with at least 5% Malapose stents, again far fewer in biometrics compared to Cypher. So both these uncovered struts as well as Malapose stents clearly higher in durable polymer, that is Cypher. Definite stent thrombosis, again fewer in biometrics compared to Cypher. And this is leaders ST elevation subset with late stent thrombosis clearly looking better in biometrics. Now this of course will lead to DAPT cover, and if you see both those who were taking 12 months DAPT cover and those who stopped short of 12 months, both these subset clearly better on late stent thrombosis in biometrics compared to Cypher. The COMFORT AMI, another biometric study, clearly showing that there is superiority with the biodegradable polymer. These are the results from the COMFORT AMI through 2 years, and stent thrombosis again looking less in this kind of subset. Now, when we compare the biodegradable polymer with the biostable polymer which stays, and these are the 3 studies, these are test 3, these are test row, and the leaders data, and you find that there were almost 25% diabetics. So biodegradable polymer clearly looks better compared to durable polymer, where the polymer stays with the stent as long as you want. In India, we are familiar with Pronova XR, and we did this study, 38 plus lengths. You know that Pronova XL comes at 43 and 48 length stents, and these were angiographic follow-up, and we had TLR of just 1.25% with no stent thrombosis in the subset. The Genex Zinc, another stent where again the polymer degrades, again an Indian stent. This was again long stents, like maybe 2 stents put together exceeding the length of 38. Again followed up with an angiogram, TLR about 2.5% in all these subsets. So whether we want to attribute everything to the degradation of polymer, I'm not sure, but I'm sure at least the stent coverage, the late stent thrombosis could be issues which are related to the polymer. The EXL technology, again, the polymer degrades, late stent thrombosis, very few, as you can see here by our definition. And now we are talking about the excess dedicated bifurcation stent, again having an abluminal coating, biodegradable polymer, Biolumus A9 as a drug, all features of biometrics built into this dedicated bifurcation stent, the diverged data, the restenosis rate, very acceptable as per the data. And we have this Indian stent, the Nile Pax. This is actually an abluminal coating and totally polymer free. This is a special nanotechnology which is used to hold the drug on the stent. Again, giving an exciting option to all of us. This is just to say that I'm not sure whether I was the correct guy to talk on polymers, but what I showed you, the data is from clinical practice, and I guess some of the results could be attributed to the degradation of the polymer over length of time. Thank you indeed for your attention.